So I'm covering a very simple topic that I know we all look after a lot, which is distal radius fracture reduction and casting. In terms of distal radius fracture reduction, it's often, I think that it's an art that we all do a lot, but we often don't think about the exact underlying mechanism that leads to the way we need to reduce it. So I'll go through the fracture reduction technique. I'll talk about what parameters we use as an acceptable parameter to take. I'll talk a little bit about casting materials. I'll talk about casting technique, moulding, and then bivalving or splitting of the cast. I will talk a lot about fiberglass casts, and the only reason why the video that I have uses fiberglass rather than plaster of Paris is because we just don't use plaster of Paris. However, all of the aspects that apply to the plaster of Paris, the fiberglass also apply to plaster of Paris. It's just a slightly different moulding technique for fiberglass. So we know the anatomic considerations of the thick periosteum that children have, and we know that it's the thick periosteum that is actually going to be what prevents us from just being able to do traction like we would in adults. If you just do traction when you've got the thick periosteum, then all you're going to achieve is, because the periosteum has to go across the triangular portion, is there is no way, no matter how strong you are, you're going to be able to overcome that triangular oblique periosteum, because it's just not long enough to go the distance that you need it to. So that's why it's important when you're reducing pediatric fractures to increase the deformity so that you relax that periosteum, then get the distraction with the periosteum in the shortened position, and then reduce the fracture down. When you do this, the fracture itself actually becomes very stable once you've reduced it, because that periosteum on the dorsal side usually will act as an internal splint to the fracture. You then are going to be placing your 3-point mould in order to go on the disrupted periosteum side over the fracture site, and then proximally and distally in order to hold your reduction. And then the periosteum's providing the splintage to that. So I always know that I'm doing the right technique when I'm in the emergency room and somebody is feeling ill in the corner. I think that I've given enough of the increased deformity, putting the hand right back onto the forearm before doing the distraction. If nobody in the room makes a comment that they think I'm doing something terrible, I know I haven't done enough increasing of the deformity to get the fracture to reduce. Once you've got the fracture over, sometimes you need to do that little rocking maneuver for non-fascial fractures. Fascial fractures, you want 1 or 2 reduction attempts only. But when you've got the metaphyseal ones, because we know that one of the risk factors for loss of position is an incomplete reduction. And the reason is that the periosteum is going to have the best mechanical advantage to help prevent the redisplacement if you've got it. If it's still going across at a triangle, it's actually acting as an ongoing deforming force. So you want to keep doing that little rocking maneuver until you can get your fracture as good as you possibly can, because that's going to make it most stable and the least risk of loss of position. We know that the acceptable reduction, we heard it in the excellent talk just before, depends on age, proximity to the physis, direction of the deformity with relation to movement of the joint. And that's key because we know that coronal plane angulations are not going to remodel nearly as well as sagittal plane, because that's the way that the wrist joint in the distal radius moves. We know that malrotation is not going to remodel, and that is going to affect both the distal radial ulnar joint but also forearm rotation. We heard right first thing this morning that we can expect about 10 degrees per year, and we can therefore, it's about 0.9 degrees per month. At Boston Children's Hospital, we constantly come against the family wanting to have a perfect x-ray, and we spend a lot of time counselling the families about acceptable parameters on x-ray. And we accept in children with greater than 2 years of growth remaining 20 degrees. And if you've got less than 2 years remaining, only 10 to 15, or even less if it's closer to the patient's closer to skeletal maturity. When applying a cast, what we don't want is a banana cast, okay? We can take the fracture in the top right and turn it into the fracture, top left and turn it into the fracture on the top right. They're the same patient, simply by putting a cast on that allows the fracture and pushes it into that position. So in terms of applying a cast, we want to focus on 4 main aspects, and depending on the exact nature of the fracture, you can't do all 4 of these all at once, and so you need to think about the fracture that you have and which of these aspects is going to be most important. The 3-point mould for the distal radius metaphysis fracture is essential, also for the Salter-Harris 2 fracture. The interosseous mould is going to be most important for the mid-diaphyseal fracture. You're wanting to use the interosseous membrane as your reduction aid to push the 2 bones apart. The supracondylar mould comes in on that very small child that's got the pudgy arm that's very short, that any cast you put on is going to want to come off. And also with those short arms, you're going to be wanting to work on getting a straight ulnar border and a straight posterior proximal humeral border, because they're what's going to prevent that bananaing. By having that straight ulnar border is going to keep the ulna straight. I won't talk much about casting index because we've got a whole talk coming on that. Although the literature says that you can put short arm casts on distal radius fractures, we in our institution can't put on good enough casts to trust our residents to put on short arm casts. So despite the literature supporting it, we don't get the 0.7 cast index consistently enough, and so we actually choose in children to continue to use long arm casts for most unstable distal radius fractures unless there's a good reason not to, because the elbow stiffness is not a problem. So I brought Dr. Bay with me, and he's actually going to present the, just let me go back to that one and hopefully it will play.
My personal preference is to use stockinette cuffs at the leading and trailing end of the cast.
Just before I have him go any further, I want to say he is using fiberglass cast, and I want to say again, it's exactly the same principles. If you're using the thicker web rule, you don't need quite as many layers of web rule as he will use here.
My personal preference is to use stockinette cuffs at the leading and trailing end of the cast. While you can use stockinette throughout the entire length of the cast, I find that allows opportunity for the stockinette to fold, create creases, and cause skin and soft tissue irritation. For that reason, my preference is to use cuffs alone. Here we will take a stockinette cuff and place it far above the level of the fracture. I have a longer cuff in which I will cut a small hole into the side, and this hole will allow the thumb to come through. I've purposely left the stockinette a bit long right now, and it's covering the fingers, and this edge will be folded down upon completion. When you're rolling web roll, it's always helpful to roll the cast padding so it literally rolls on the surface of the skin. Note that I'm holding the web roll at the axes of the spool, allows an easier rolling of the web roll, and by applying differential tension on the trailing end or leading end, I can have this web roll lie very flush with the skin without the creation of any wrinkles or abnormal bare spots. In general, people always wonder how much web roll is enough. And although we like 2 to 3 layers along the way, certainly providing adequate cast padding is critical so as to avoid complications such as skin burns or cast saw injuries that are important to keep in mind when providing cast padding and as well as fiberglass application distally in the first web space and in the distal aspect of the cast. Number one, we'd like to keep the metacarpal phalangeal joints free to avoid digital stiffness, allow us to have an adequate motor and neurovascular examination, and to facilitate functional use of the hand. I find that it's helpful in these situations to take a piece of the web roll and break it off. In most children, it is helpful to fold the width of this in half and set the level, the distal level of my cast, just proximal to the metacarpal phalangeal joints. So there we have 2 layers of web roll. I'll repeat the same process, take a strip off, fold it in half, and again set my level just proximal to the metacarpal phalangeal joints. I acknowledge again that in this particular distal radius fracture model, the first web space cannot be opened, and that's something we would want open in real clinical practice. Characteristically at this stage, if we've rolled web roll from proximal to distal and set our cast padding level distally, it is very common to see a triangular bare area here dorsally, as well as a bare triangular area here volarly. To provide adequate cast padding, we can simply break off small strips. I find it helpful to poke a hole in the middle of the web roll, put the thumb through the hole, and then cover those triangular bare spots, either by going through the thumb, like so, or coming around the base of the thumb. Temperature or ambient temperature water. Again, holding the spool of the fiberglass at its axes and positioning the roll so it can roll very easily. We will begin by applying the fiberglass, overlapping as we go along the length of the desired cast.
You'll notice he'll put on less layers.
There are a couple different maneuvers that can be used to provide adequate fiberglass passage through the first web space. My personal preference, and I'm going to turn the model this way to show it, is to bring the fiberglass just to one edge of the thumb, hold it in place, and fold the fiberglass back.
This really
I will then
helps
pass
to
it
get that
just
palm apart
to the
more
other
solid.
edge of the thumb. Okay, enough order. Yeah. Pinch it and fold it back. In this fashion, I can go back and forth and cover those characteristic bare spots using my other hand to stabilize these folded ends. At this point in time, to facilitate fiberglass passage, what I will do typically is take a short length of fiberglass and twist it. Twisting allows the fiberglass to have a narrower width, but will actually provide sufficient strength.
With plaster of Paris, you can do the
Once that twist has been created, I will simply lay it in the first web space. I will try hard not to pull too tight so as to avoid excessive constriction. I will lay it in the first web space and then roll. I can capture this folded edge of the fiberglass as I come around, and I will capture what is characteristically this loose corner by coming around. That typically is sufficient for the distal edge of the cast in the first web space. These prior stockinette cuffs can be folded over. Notice that I've left a little bit of extra web roll here to provide a nice padded edge to the cast. So too, in the distal aspect of my cast, I've given myself plenty of stockinette. What I can do is I can make another counter cut here, and as I fold this back, that counter cut should allow me to pass my thumb through the stockinette. So I have a very nicely padded trailing edge of the cast and a padded first web space.
This also stops children from pulling the stuffing out of their cast because it actually contains all of the web roll and the soft stuff within the cast. So in terms of moulding the cast, the fiberglass technique is a little different. So plaster of Paris, you spend a lot of time rubbing, but Dr. Bay will go through the difference in the fiberglass.
At this point in time, in effort to maximize production and maintenance alignment, we can provide either a 3-point bending mold to help counteract the deforming forces and avoid redisplacement.
So if you're doing this with
For
plaster,
diaphyseal
you
form
need to get
fractures,
a third point,
this was
either
a
another
longer
person
cast.
or you
We can use the ulnar borders of our hands or our fingers to create an interosseous mold.
If we're doing an interosseous mold in general, we're doing
to
a long arm
maximize
cast.
the interosseous space between the radius and the ulna. And sometimes, by applying differential pressure, we can apply both a bending mold and an interosseous mold at the same time.
So that's sort of the ones that are
periodically, I will release that mold and really rub along the ulnar border of the cast, particularly in a long arm cast, to try to maintain a straight ulnar contour.
Okay, so the principles are exactly the same. We use all fiberglass, so all of our casts we bivalve, but with plaster of Paris univalving. In terms of when to bivalve and when to split a cast, it actually really helps with reducing the pressure within the cast. So we will do it on any fracture that has been reduced, any high injury, energy injury, any time that we have concern that the family might not be able to fully comprehend the necessity to come back if the child gets pain, or if we keep thinking about doing it, we do it because there's clearly a reason why you're concerned. Thank you very much.